Good evening, everyone. Thank you so much for joining us. It's a pleasure to have you, and I hand you over directly to our moderator for the Pediatric Association of Jamaica's Autism webinar today, sponsored by Square Pharmaceuticals, Dr. Ludwig Morris. Dr. Morris, over to you.
Good evening, ladies and gentlemen. I just want to thank you for joining us today. And today we have this webinar that we'll be looking at autism. And the Pediatric Association of Jamaica is focusing on autism all year this year. And so we bring this seminar to you, and I'm so grateful to see all of the persons who have joined in this evening. I now ask the president of the Pediatric Association of Jamaica, Dr. Curtis Price, to bring us greetings and opening remarks. Dr. Curtis Price, over to you.
Good night, everyone. About 1 in 36 children, according to the CDC, has been identified with autism spectrum disorder and developmental disability. That's according to the Monitoring Network, ADDM. ASD is reported to occur in all racial, ethnic, and socioeconomic groups. Of course, ASD, which is autism spectrum disorder, is nearly 4 times more common among boys than among girls. About 1 in 6 children aged 3 to 17 were diagnosed with a disability, a developmental disability, in 2023. Autism is a problem. And just looking at the number of persons we have registered for this webinar, I mean, when we sent out the invitation, within the first couple of days, I think we had over 700 persons registering for this autism webinar. So it's a problem worldwide, but it's even a greater problem for us in Jamaica. First, the specific cause of autism is not known. Then it is not a highly specific disease entity, but is regarded as a spectrum. It's an emotionally challenging disorder. And finally, treatment itself is a challenge. We meet patients every day in our offices, venting about the challenges that they have accessing service, getting a diagnostic done, long queues, long waiting, and that sort of thing. So there are challenges in finding a therapist, challenges in finding a specialized academic, environment, a special school, the parents will tell us, waiting in long queues for appointments, and not to mention the heavy financial commitments on parents and caregivers. Tonight, we will explore some of these challenges, and we look at some of the ways as a group, as an association, and we extend this, we encourage other associations to join in, where we can charter a clearer path towards making the lives of children with autism in Jamaica a little more tolerable. I want to thank you all for joining. God bless you and have a wonderful rest of the night.
Thank you, Dr. Price. And having said that, we will jump right into the presentations. And at this point in time, I'm going to invite Professor Maureen Sams-Vaughan to come to us. But first, let me introduce Professor. Professor Maureen Sams-Vaughan is known locally, regionally, and internationally for seminal research, clinical work, and policy development in the field of child health, child development, and behavior. She's also recognized as an advocate for the well-being of all children, but particularly so for those at the early childhood level, those with disabilities, and those who have been victims of violence. She works very closely with families of children with autism. She has served in a number of academic UWI positions since 1993 and was appointed UWI's first professor of child health, child development and behavior in 2006. She has been consultant developmental and behavioral pediatrician at the UHWI and director of the weekly child and family clinic for children with developmental disabilities and behavioral disorders since its inception in 1993. She has taught at the undergraduate and postgraduate levels throughout the UWI and has supervised doctoral students at the UWI and at several universities in the USA in child development research. She has adjunct professorial status at universities in the USA. She retired from the UHWI and UWI in August 2022 and was subsequently appointed Professor Emeritus at the UWI. Prof. Samswan has over 120 publications, including 3 books, several book chapters, and peer-reviewed papers on a range of child development and behavioral related topics. She has also completed numerous consultancies in the field of child development and behavior at the IDB, the World Bank, UNICEF, PAHO, and the governments of the Caribbean. She's currently a member of the IDB's Advisory Group on Early Childhood Development. She has received numerous research grants for child development research from UNICEF and the IDB, the World Bank, the National Institutes of Health, and Canada Fund. Her most recent research, the Jamaica Kids Study, a national birth cohort study of 9,700 Jamaican children and families, which commenced in 2011, has identified factors that promote and prevent optimum development for Jamaica's young children. Prior research on fatherhood in Jamaica has been featured on a National Geographic television program on testosterone and fatherhood. Administratively, she was appointed head of the Department of Child Health in 2001, a position which was relinquished when seconded to the government of Jamaica to guide the development of its new agency, the Early Childhood Commission. She has been a member of the Government of Jamaica's National Advisory Council on Disability and the National Council on Education. She currently serves as a Director of Family Life Ministries, the Usain Bolt Foundation, and a number of school boards, and is a patron of the Jamaica Autism Support Association, which is a parent support group for children with autism. She serves as co-chair of the international organization No Violence, which was established to reduce violence against children globally. She was a commissioner of the Jamaica Education Transformation Commission, established by the Prime Minister in 2020. The Education Transformation Commission submitted its final report in 2022. She currently chairs the National Commission on Violence Prevention, established by the Prime Minister in 2019. The NCVP will present a 10-year comprehensive evidence-based plan for violence prevention in 2024. She was appointed the first chairman of the Early Childhood Commission, a body established by the government of Jamaica to develop the country's early childhood sector in 2003, and served in this position until 2016. Under her leadership, the Early Childhood Commission developed and implemented Jamaica's first cross-sectional national strategic plan for the early childhood development in 2008 to 2013. The Early Childhood Commission is now implementing the third follow-on plan, 2018 to 2023. The plan addresses parenting, well child care and nutrition, screening and early intervention, regulation of early childhood institutions, training of early childhood practitioners, coordinated sector-wide planning and budgeting, monitoring and evaluation of child development. She has also guided the Early Childhood Commission in the development of Jamaica's national parenting policy and has coordinated the early development of Jamaica's early childhood development policy. The structure and function of the Early Childhood Commission and the National Strategic Plan for the Early Childhood Development have been recognized as international models by the World Bank, IDB, and UNICEF. Among the achievements of which she is most proud are the development of the standards and regulatory system for early childhood centers, the development of Jamaica's Child Health and Development Passport, a parent-held record provided to all Jamaican children at their birth since 2010 September, and which is used for early identification of developmental disabilities, the development of the National Jamaica School Readiness Assessment, an assessment to identify children with developmental and behavioral disabilities at 4 years, and the development of the Early Childhood Commission strategy for optimum development of children 0 to 2 years. The first 1,000 days and approach and Jamaica Brain Builder strategy. Prof. Samzwan relinquished her chairmanship of the ECC in April 2016 after almost 13 years of public service in that area. She has been recognized by each of her alma maters, Vasprep, Excelsior High, as an outstanding past student. She was the recipient of the Soroptimist International and Women's Leadership Initiative 50th Anniversary Award in 2012. She has been recognized by the UWI as an outstanding researcher on numerous occasions, and in addition, has received the UWI's Vice Chancellor's Award for Excellence in Public Service in 2010, and the UWI's Principal Award for the Translation of Research into Public Policy in 2019. In 2020, she was appointed the International Society for Autism Research Global Senior Leader for Jamaica. In 2022, she was recognized by the Caribbean community of retired persons as a living legend. Her work was first recognized by the government of Jamaica in 2007 with the award of the Jamaica's 5th National Honor, Commander of the Order of Distinction for pioneering work in early childhood development and child health care. In 2022, she was awarded Jamaica's 4th highest national honor, the Order of Jamaica for pioneering research, clinical work, and policy development in the field of child health, child development, and behavior. Prof. Samzwan and her husband, Kenneth, an orthopedic surgeon, worship at the St. Matthew's Anglican Church. They have 3 young adult children, Stephanie, an attorney, Nicholas, an environmental scientist, and Christina, a developmental economist with the World Bank. So, Prof. Marine Samzwan is more than qualified to speak to us on autism. Prof, over to you.
Okay, thank you, Ledrick. That was a pretty long introduction. So I'm going to try to catch back some of that time. Thanks to the PAJ for this opportunity. I'm really pleased to note how many persons are on the webinar today, because really we need lots of persons to understand autism and to help parents and families in Jamaica. So the first thing we have to do in this presentation is to define autism. And we're using the DSM-5 definition that it's a developmental disorder. And it's characterized by deficits in social communication and social interaction and restricted repetitive behaviors, interests, and activities. I'll explain some of these a little bit later. It's important to note that previously the definition included communication and social skills separately, but now it's combined. So this is one of the things that concerns persons, that, you know, if you look at just the prevalence of autism, it seems to have increased 417% since 2000. Dr. Price mentioned the ADDM and the CDC monitoring, and that has been going on since 2007. So since 2007, we have had monitoring in the same almost the same way, not quite, because they have also changed how they monitor as we've learned more and more about autism. And you can see that we are now, as he said earlier, at 1 in 36. 1 in 36 is a pretty common number. But when we look at what's happening across the world, we see that there are 4.6 million children who have been identified with autism. I'm sure there are a whole lot who have not been identified. The world figure is 1 in 138, and we see that large numbers of children with autism are in low and middle income countries, which makes sense because that's where the largest numbers of children live. In Jamaica, with our birth rate bouncing somewhere between 32, 33,000, a rate of 1 in 6 gives us close to 900 children per year being born with autism in Jamaica. So everyone keeps asking, is there an epidemic? Is there an epidemic? Well, the information that we have right now doesn't suggest so, because when you look at the United States, for example, where because they monitor every 2 years, they have a very clear idea of what is happening in school districts and what is happening in different states. There's such wide variation across the states and even within states across school districts that wide variation doesn't seem to have a biological basis. The problem, you see, is that there isn't a definitive biological test for autism, and that means that diagnosis is dependent on observation by highly trained professionals, particularly for the milder cases. We are now aware of a bit broader concept of autism, and we are now aware of milder cases, particularly among persons with normal to very high intelligence. And the changes that have happened in diagnostic criteria over time, as we have learned more about the condition, has meant that we are now diagnosing more and more children. You know, it's similar to most conditions in medicine. You first identify the most severe aspect of that condition, and then you learn about milder and milder presentations with time. There's also been an increased availability of diagnostic services. And the changes over time have really suggested to us that it's not new cases, but that we're doing better with identification. So, for example, the prevalence of intellectual impairment, disability has changed with time. At first, we used to think that 80% of children with autism spectrum disorder had developmental delay or intellectual disability. Now we're down to 61%. We've also seen that the prevalence among African-American children in the United States has changed over time. So you see that in 2017, the proportion of white children was higher than that of Black children. Now in 2021, the proportion of Black children is higher than white children. And what is happening is here that there has been an increase in reaching out to underserved communities. And so more Black children were identified. We're also expecting that as time goes on, the male to female ratio with 4 males to 1 female, we're also expecting that to change as we learn more about girls with autism. We're learning that girls with autism have a greater preservation of their social skills. So they don't get diagnosed as early. They're quieter, they're calmer, they don't get diagnosed as early. So we're expecting that that ratio is going to change with time. As was said earlier, it occurs in all ethnic groups, all socioeconomic groups, and the difference in prevalence rates likely reflect access to services. It's important to understand the risk factors that are associated with autism. We have 2 main ones. First are the genetic risk factors. So in one study that didn't look at gene-environment interaction, they identified that 80% of autism was due to inheritable genetic effects. We have identified through research a large number of genes, but we have not yet come down to a single gene or a few genes. But genetics is important based on what we know happens. So the risk of a second child with autism increases 10 times after you've had a first child. And we know that the risk is increased among cousins, identical twins, and to a lesser extent in non-identical twins. And it's also associated with a lot of genetic syndromes. The second main risk factor is the prenatal and the early environment. So parental age at conception is a significant risk factor. If you're 35 years or over, at the time of conception, you move into a much higher risk category. Maternal illnesses, particularly a fever, exposure to pesticides and pollution, have also been associated with autism, and there's a higher risk in children who are born premature and of low birth weight. I put this up because, you know, everyone talks about vaccines, and there was an original study that was published, but since that study, nobody has been able to reproduce this study. And indeed, this study linking autism to vaccines was withdrawn and retracted by the journal because of problems with this study itself, poor design and very questionable research. In order for us to manage autism, it's important for us to be able to identify it well. I mentioned earlier the deficits in social interaction and social communication, and we can break that up into 3 different ones: deficits in social emotional reciprocity, deficits in nonverbal communication. You know, we all communicate nonverbally. We use our hands, we use our face, we use all aspects of our body to communicate nonverbally. And the children with autism also have deficits in developing, maintaining, and understanding relationships. Because of time, I won't be able to go through all of these, but I'll just highlight a few. In terms of our social communications, almost any form of abnormality of speech is associated with autism. Some children are nonverbal, some children start speaking, some children stop speaking after they've started, some children have delayed speech. Some children use speech, but only to meet their needs. Some children have some speech, but they can't keep a conversation going. Some children use robotic speech, they speak with an accent, they never speak Jamaican patois, and they're often asked if they come from foreign. There's also failure to initiate or respond to social interaction. So smiling, interacting, somebody engaging with them, it's not returned. There is reduced sharing of interests, emotions, or affects, so they don't engage with others and share with them. They're often unable to express their own emotions or feelings. They can't say they're happy, they're sad, and they seem to be unaware of other people's feelings. They often inappropriately approach a social interaction by being aggressive. So a child may, for example, come and hit another one because they're trying to get their attention and they don't understand that that's not an appropriate way to get attention. Other aspects are limited or unusual eye contact, limited or unusual facial expression. So some children can't show the variety in facial expressions that we would normally use. They also have deficits in understanding and using gestures. So the typical child who'll be pointing by 18 months, waving by a year, those may not happen. They may adopt unusual body positions, tensing of the body, walking on the toes. They may also have difficulty recognizing nonverbal cues. So they don't understand when they often don't understand where they belong, the tone of voice, the body language, they don't understand that very well at all. They often fail to respond to their name or appear not to be paying attention. They may resist affection. They may not show the typical pretend play, you know, hugging a doll, feeding a doll. They may show no interest in their peers. This is often noticed by the preschool teachers when they get to school. And they sometimes just play by themselves. They often too can't modulate their behavior in different social contexts. So they will want to run around and scream in places where persons would normally wish to be quiet. In terms of the behaviors and interests, they may have stereotyped or repetitive motor movements and use of objects, especially stacking, flapping, and spinning of objects. Those are the most common ones. But because of that middle bit in the autism spectrum disorder, there's a whole range of unusual motor movements. They may also have repetitive speech, use the same phrases over and over, or indeed create their own words for objects or situations. They like sameness, so they like routines, and there can be extreme distress at small changes of furniture in the home, but there can also be distress at changes such as would have happened now, change of a class teacher. So children with autism often have challenges with changing classroom, changing teachers. They have difficulty with transitions, and some of their sameness extends to their food. So, you know, some children with autism will eat 5 things and nothing else. There may be hyper or hyporeactivity to sensory input. So this would manifest as sensitivity to sound, covering their ears to loud sound, to touch, rubbing surfaces, rubbing walls, feeling airs, feeling noses, taste, and smell. They may smell everything that they're given. They often have a visual fascination with lights, motion, and fans, and sometimes they have an indifference to pain and temperature. Now, so I have told you so many different things about autism, and importantly is that nobody has everything, and nobody has everything to the same degree. And so 2 children with autism can be completely different. There are other features that we see with autism. We see a large head size or a small, we see large head size or large body size. When neurologists are doing their evaluations or pediatricians, they may have increased tone or increased reflexes, or in fact decreased. They often have impaired fine motor coordination. So they're later at holding a spoon, tying their laces, brushing their teeth, writing. And sadly, many children get punished at school because of this fine motor coordination problem. 1 in every 3 children has seizures, and sometimes the seizures occur before the features of autism are manifest to others. They may have a number of gastrointestinal problems, constipation, diarrhea, reflux, and I mentioned the food selectivity earlier. Overweight and obesity is very common in children with autism, affecting almost a half. There may be additional behavioral features, and a lot of children with autism have ADHD as the commonest feature. And sometimes the ADHD is diagnosed long before the autism. And for some children, the ADHD is more of a problem than the autism. They may also present with aggression, self-injurious behavior, irritability. Many have sleep disorders. Many have unusual fears, depression, mood disorders. And when they get to adulthood, there can be the emergence of schizophrenia and psychosis. Global developmental delay in children up to the age of 5 years and intellectual disability in children from 6 years on occurs in 60% of children. But even in children who do not have intellectual disability, they may have learning difficulties. They may have visuospatial difficulties, or indeed, some may have advanced visuospatial skills. So some children, for example, can do puzzles way out of the what would be expected for their developmental age. Again, some children may be able to read words way out of the age that one would expect. In fact, some children teach themselves to read, and that's known as hyperlexia. The problem with hyperlexia is that it's not always associated with an understanding of the words. I wanted to mention the features in the older child because much of what I mentioned had to do with the younger child. The older child comes to attention later on, late primary, in secondary school. And these children often have normal to high intellect. They are socially awkward. And when they get to high school, they don't understand where they don't belong. And they're often considered weird by their peers. They don't often have lots of friends. And because the children are very tuned in to the fact that they're different, they don't understand why they're different, but they know that they're different to everyone else. They're often bullied. And you can see that bullying occurs in about 2/3 of children. They're often considered rude or inappropriate to adults because they have no social filters. So they just say what comes to their mind. One of my patients came in and told me, "Doc, do you know you're getting old?" But because I knew he had autism, I knew exactly where that was coming from. And their language, very important. The speaking with an accent, I mentioned earlier, the fact that they speak only Jamaican Standard English and don't often speak Jamaican Patois. And this often makes them stick out at school. So many children with autism at high school are trying to study Patois. Now, the average Jamaican child doesn't have to study that, but the children with autism are studying it. The impaired fine motor skills sticks out very much in high school because they can't write as fast. Their writing is often very, very poor, often illegible. And because earlier on, I mentioned the challenges with pretending, they have extreme difficulty with literature in high school because they have to understand what another person is trying to think or feel. And this is one of the deficits in the condition. What is important for persons as general practitioners, as pediatricians, as teachers, your main role is screening and early identification of persons with autism. The American Academy of Pediatrics recommends screening for autism at 2 points, 18 and 30 or 24-month well-child visit. There are a number of screening tools, but the one that has been most widely used is the MCHAT, which has been revised, the MCHAT-R. And, it's freely available online. If you have any concerns at all about a child, pull down the MCHAT and all the information is available about scoring it. However, within the Child Health Passport, there's also information about autism. It's not specifically labeled autism, but at the 18-month visit, there are 5 questions to the right. Those were selected from the MCHAT. Those were the most highly validated questions, and those were selected from the MCHAT for early identification of children with autism. The Child Health and Development Passport is being revised, and a longer screen may be included. So these are some key milestones that you can use to guide parents when children need to seek further developmental intervention. Not smiling by 6 months, not showing facial expressions by 9 months, not babbling or cooing by 12 months, not pointing or waving by 14 months, not saying single words by 16 months, not having pretend play by 18 months, and not saying 2-word phrases by 24 months. And of course, losing language or social skills at any age is a concern. Once a child has been screened, it is important to refer them on for diagnostic evaluation. The recommendation is that once you identify a child with developmental delay, whether you think the child has autism or not, it's important to refer the child on for evaluation and diagnosis. That's usually done for very young children by a developmental pediatrician or a developmental psychologist. It's also recommended that early intervention is done immediately, and the public sector program for early intervention is the Early Stimulation Program, which you will hear more about later on today. It's also important to ensure that there is audiological evaluation to exclude hearing impairment. It's important to look for in your history the features of autism, the associated conditions, the risk factors, and it's also important to look for other causes of speech delay and unusual behaviors in children. Oftentimes, though, we focus only on the negatives, and so it's important to assess the child and family strengths as well as challenges. Physical examination is focused on looking for the anthropometry. Remember, I mentioned the large head size, the large body size, and also any associated neurological conditions. And the child is typically scheduled for diagnostic evaluation. The specialist evaluations would entail the use of standardized tests, would entail a developmental or a psychoeducational assessment for older children, and would also entail an adaptive function assessment, which assesses how the child functions in their day-to-day environment. Usually, there is also an assessment for comorbid conditions because many children with autism have other conditions, as I mentioned earlier. Remember that brain imaging is not required unless there are abnormal neurological findings. The treatment of autism is geared at minimizing core features, maximizing independence, maximizing quality of life, and maximizing family function. Early developmental intervention and behavior therapy have been shown to be equally effective in improving children's outcome. Speech therapy, absolutely critical. I mentioned many of the communication disorders. You'll hear more about that later on. occupational therapy for coordination problems, and importantly, educational placement. The research is very clear that children do better in an inclusive environment. We have more integrated environments than inclusive environments in Jamaica, and we really need to be moving more to the inclusive setting. That's where children with disabilities are in the same classroom with children without disabilities. Because children with autism have impairment in their social skills interventions are often utilized. So social skills groups for older children and social stories to guide younger children to teach them about what is typical social behavior. We may have to use medication to address aggressive behaviors and ADHD. We may have to use melatonin to address the sleep disorders that may occur, and anti-epileptics to address seizures. The cost of care in the US for all this care is estimated at $60,000 US per year per child. It's important that we not only address the child, but we also address the family. So parental and family education is important, and parental and family support. The Jamaica Autism Support Association is our very active advocacy group for parents of children with autism. The Jamaica Council for Persons with Disabilities also offers support. And, many parents and family members benefit from psychological support. The outcome is dependent on how severe the condition is and the degree of intellectual impairment. Many young adults with autism, sadly, after they come out of the pediatric age group, they do not receive any healthcare further. More than 50% of young adults with autism are unemployed and unenrolled in higher education after high school. But I need you to note that this is a lower rate, although it's so low, it's a lower rate than that for other disabilities. And that is primarily because of the larger proportion of children with autism that have normal to high intellect. But even among that group, the proportion that are in higher education is also low. Thank you all for listening. I will be here to take questions.
Thank you so much, Prof, for going through autism in such comprehensive manner. I'm sure that all the persons in the audience have really feasted on this presentation and is digesting, and I'm sure it will be good nourishment for our brains to action. So thank you so much, Prof. We're going to take questions after the next presentation. So I'm going to invite Miss Anne-Marita Golding to come to us. She is a licensed speech and language pathologist certified by the American Speech Language Hearing Association, with over 8 years of experience working in Jamaica and the United States in the areas of subacute rehabilitation, school-based therapy, and in private practice. She's trained to assess, diagnose, and treat communication and swallowing disorders in both adults and children using a family-centered approach with specialized training in aphasia associated with stroke rehabilitation and traumatic brain injury. She's a licensed speech pathologist, licensed speech language pathologist in Florida, USA, and in Jamaica. She has a certificate of clinical competence in speech language pathology, certified by the American Speech Language Hearing Association. She has experience in founder and clinical director, speech and swallow rehab therapy services. She's also a consultant speech language pathologist at Rehabilitation Institute of the Caribbean, provided speech and language therapy to children and adults with a variety of communication disorders. She is a consultant speech language pathologist at Rockhouse Foundation at in Savlamar Inclusive Infant Academy from 2019 to 2020. She was a speech language pathologist at Hebrews Home, Rockville, Maryland from 2015 to 2017. She has publication on swallowing disorders in children with cerebral palsy, and she also published on dementia, the living nightmare we better need to understand, and that was in Jamaica Gleaner on June 20, 2016. Please help me welcome Miss Anne-Marita Golding to speak to us on speech and language pathologist intervention in autism. Over to you, Mrs. Golding. Miss Golding, sorry.
Thank you so much. Thank you for that introduction. And I want to thank the Paediatric Association of Jamaica for inviting me. I'm happy to be here today. Much of my presentation, Dr. Prof already covered much of the introduction to autism. And so I'm going to pull up my slides and share that with you, but I'm going to skip over much of it because she has already covered, covered that part. All right, so want to highlight speech language pathology as it pertains to autism spectrum disorder. As a speech language pathologist, I work heavily, probably more than 90% of my clientele in private practice are kids, and much of that are kids on the autism spectrum. So Doc already covered what autism spectrum is. You know, it's a developmental disorder, and it heavily affects that child diagnosed with ASD, affects their communication and their behavior. And as she mentioned, 1 in 36 babies in the US, according to the CDC, are diagnosed with ASD annually. And that seems to be, to Joe public to be increasing, because we do get that question a lot. You know, how is this becoming more prevalent? And she explained that as well. The factors include changing in the diagnostic criteria, environmental factors, genetic factors, and increased awareness and understanding of the disorder. Now, as it pertains to communication and where speech pathologists come in, children may have difficulty with expressive language, receptive language, and pragmatic language and social skills. And those are the areas that speech language pathologists address heavily when they're working with children on the autism spectrum. Let's look at what speech pathology is. Now, the official term and title for the profession is speech language pathology. That is what is known internationally. But here in Jamaica, we more commonly say speech therapist or speech therapy. So it is interchangeable. It's the same thing. A speech pathologist is a speech therapist. Speech pathology is the study of communication disorders. But what we provide in the clinic and in different clinical settings and schools is speech therapy. This is the study and treatment of communication disorders, as I mentioned. A speech pathologist is trained and licensed. And you're going to hear me emphasize licensed throughout this presentation, and I will let you know why as I go along. But it is important as practitioners, as individuals seeking services, to ensure that you are doing your due diligence and seeking a speech pathologist that doesn't only say they're a speech therapist, but that they have the prerequisite licensure and qualifications to treat you or your loved one. So it's a trained, an SLP, as I will use the term, is a licensed allied health professional who specializes in the evaluation, diagnosis, treatment, and prevention of communication disorders, cognitive communication disorders, voice disorders, pragmatic disorders, social communication deficits, and swallow disorders in individuals of all ages. What is the role of a SLP in the treatment and management of autism spectrum disorder? SLPs will gather and review a detailed case history. That tends to be where we start with interviewing the family and doing informal observation of the child. Using an interdisciplinary approach to include parents and caregivers, pediatricians, or even general practitioners, developmental psychologists and school teachers to assess the child using formal and informal assessments. Once a diagnosis of autism spectrum disorder is suspected, or there are indicators that the child may be on the spectrum, a recommendation for skilled speech therapy will be made, and an individualized treatment plan will be assembled with each therapy session, which will guide each therapy session. So a licensed speech pathologist is trained to assess. Usually we're able to very quickly recognize through gathering a case history and spending time with that child and doing formal and informal testing and assessment, we can begin to get an idea of whether this child may likely to be on the autism spectrum. At that point, we usually refer to a developmental pediatrician or a developmental psychologist for further assessment, so that that family can have a diagnosis and we can move from there. A diagnosis is not required for the child to start speech therapy. It is, once we notice that there's a deficit in communication, we're able to put that child on caseload once a space is available, depending on where that child is receiving services, and begin speech therapy by charting a treatment plan tailored to addressing the deficits or challenges that that child may be having. SLPs can work with children diagnosed with autism spectrum one-on-one or in small groups, or even via teletherapy. I know in my own private practice, very soon we're rolling out a program of group therapy because there's just not enough time slots for one-on-one, and the need for therapists, as we all know in Jamaica, is very, very high. It's dire, actually. And I'm going to speak a little bit more about that once we get into some of the challenges and limitations. As it pertains to teletherapy, ever since COVID hit, a lot of speech therapists had to begin to use teletherapy to see their clients. My personal experiences with kids diagnosed with autism and on the autism spectrum, it becomes sometimes very challenging because you're not sitting in front of the child, and the parent or caregiver, most times it's a caregiver, is unable to provide the necessary assistance needed so that the child can participate in the session continually and benefit from the session. Usually when a child is relatively high functioning, that child is able to sit for longer periods and cooperate with minimal assistance. But teletherapy can prove to be a challenge depending on the challenges and needs of that particular child. The specific speech and language goals targeted will vary depending on the child's need. As Professor Samsvan mentioned, no two children on the spectrum are the same. They have their strengths and their weaknesses, and so we tailor our goals to address those specifically. SLPs also make specific recommendations and provide parent-caregiver education to facilitate progress, continuity, and carryover for the child. It's very, very important that parents have an idea and they're well informed and equipped with resources, particularly things that they can watch and read. We know parents don't have a lot of time. We know that they have a lot on their hands, particularly when they have a child with special needs and they have other children. It is difficult for them to spend a lot of time searching for information. So the more education and training that we can provide within a clinical setting, the better off for that child and for that family, and better off in terms of carryover. I've experienced many times when parents drop off their child to the clinic or they send with a caregiver, and they have no idea what's going on. You ask them to come in so that you can give them feedback, but not, that information is not always put into practice at home. So materials given to the family and follow-up is very helpful. Let's look at some common goals addressed in therapy. So comprehension. And when we speak of comprehension, we're referring to receptive language skill. Receptive language skill is where I tend to start personally as a therapist. It's extremely important to work on comprehension, because if that child is having severe deficits in following basic commands, demonstrating basic comprehension, or deficits in understanding vocabulary, answering something like answering yes or no questions. These are areas that must be addressed so that we can begin to work on the expressive language side of it. So within receptive language and comprehension, we have following basic commands, identification of common objects, and responding to yes and no questions, whether verbally or non-verbally. And non-verbally can look like a head nod or a head shake. Expressive language skill addresses things like vocabulary and naming. You may find that a child who is non-verbal can identify many objects, so they have vocabulary, but their ability to use it is where their challenge is. And so expressive language also deals with requesting, using verbal requests or nonverbal requests by pointing, increasing MLUs, which is mean length utterances, speaking in longer phrases, and expanding their language skill through using more words in expression. SLPs also work on improving grammar, syntax, articulation, and intelligibility. Intelligibility is being able to understand what the child is saying, because they're stringing together words in an articulate way. Common goals also addressed include pragmatic language skill, and that's using language within a social context. Language isn't always literal. You find that kids on the autism spectrum may not fully grasp or understand non-literal speech or expressions. That's something that we tend to work on to improve their communication and conversational skills if they are verbal, as well as we address social skills, which are used daily to interact with familiar and unfamiliar communication partners and navigate the community in which they live and exist. So methods of intervention. The most popular, and in my opinion, the most recommended, is play-based therapy when dealing with children. This type of therapy uses interactive play activities to help kids to learn new speech and language skills needed for communication. Behavioral intervention, not to be confused with applied behavioral analysis, ABA. These interventions use positive reinforcement to teach new skill, and a family-centered intervention involves family members or caregivers in the treatment process. Now, Professor Sams Vaughan mentioned, when do I seek a speech therapy assessment? When is it recommended? So research has shown that, contrary to what has been the age of detection of ASD in the past, a lot of people probably have gotten their diagnosis around 3 or 4. There are early signs of autism that can be observed from as early as 16 to 18 months. And these are early signs that you can look out for and that medical doctors can look out for. And what these signs tell us is that it is likely that further assessment is needed. Prof spoke to early detection and intervention and how important that is to improve that child's functional skill and functional communication skill. And she mentioned many of them. I'll just run through a few. Hard to get the child to look at you. That's rarely shares enjoyment with you, rarely shares interest, rarely responds to their name or other bids. Limited use of gestures such as pointing, or they may use your hand to point or use your hand as a tool. Hard to look at you and use gestures, little to no imitating, repetitive behaviors, more interested in objects than people, usually moving their fingers and hands in a particular way, which we know the term is called stimming. Repetitive and unusual movements of objects, not using objects for their given purpose, develops rituals, and they get very upset if that routine or ritual is changed. There are a few more are here. They have strong interest in unusual sensory experiences, and they have, unusual reactions to sounds, sights, and textures. Early intervention, again, this cannot be stressed more. Speech language pathologists are trained, and some are specialized in working in early intervention, which is that 0 to 3 population. As well, early intervention is useful in promoting good functional communication habits early and to mitigate against common speech and language delays associated with ASD. The earlier we're able to get in there with a child, the better. A lot of people, tend to want to, watch, wait, and see. As a speech pathologist, and many of my colleagues would support me in sharing with you that is not something we recommend. We don't recommend a watch and wait approach. We recommend that if you suspect that something may be different about your child, something doesn't feel right, speak to your pediatrician, speak to your medical practitioner, and have them guide you so that you can seek services to have the child assessed further, even if it is by a speech therapist, to see what may be happening with their communication skills. We don't always end up with a ASD diagnosis. Sometimes it's just a language delay, which we saw a lot of with the children coming out of the pandemic who were at home understimulated. And we saw a lot of that didn't always turn out to be autism. But it's important to recognize that early detection is key to improve functionality for that child. The Jamaica Speech and Hearing Association, of which I am the sitting president, was formed to welcome, support, and protect the members of the esteemed profession. The profession, like other recognized allied health professions, are monitored and held accountable by the Council of Professions Supplementary to Medicine. We are also licensed by them here in Jamaica. The Jamaica Speech and Hearing Association currently has 11 members, 9 licensed speech pathologists and 2 licensed audiologists. And the requirements to be licensed as a speech pathologist here in Jamaica is that one must hold a minimum master's degree in speech language pathology or audiology. And they must hold a valid license or certificate of clinical competency from the country in which the licensure was granted. They must also maintain continuing education credits, and it's a minimum of 10 credits annually. Now, they asked me to speak specifically to the limitations of the profession, and we know that there are limitations because there are so few of us here in Jamaica, and many of you who are pediatricians or who have an interest in autism spectrum disorder know that the services are not easily accessible because there are not many of us here, and I'll go into why. The coursework and degree is not offered here in Jamaica. I know there was intention and talk to try to implement a program here at the university at some point, but that has not been done. And forces individuals to require overseas tertiary education to pursue the profession. I personally studied at Howard University in Washington, D.C., both undergrad and grad, and I was able to do speech pathology there because I was guided into the program. And many people don't know about the program because it's not offered here, and they may not have ever heard of the program. So not enough public education in secondary schools to encourage students to pursue the profession. And that is something that, as president of JASHA, my intention is to do more public education and have more advocacy for young people in secondary schools and those who are contemplating the subjects they want to take when they go into college. That is something that is very important to us as an association. Another limitation is brain drain. Many students stay overseas following the completion of their degrees due to higher pay scale in North America and Europe. It is by the grace of God that I came home. Even though I always intended to come home, I actually came home earlier than planned, and happily did so now that I see that the need here is so great. Speech language pathology services are not offered in the public health system. They had been offered in the public health system prior, but too few, there are not enough of us, one, and then the pay scale, as I mentioned here, the public health pace, the scaling of the profession is outdated and unappealing to newly trained speech language pathologists returning from overseas. And as a result, SLPs begin working in private practice or simply working for themselves. Too few SLPs are practicing outside of Kingston. Right now, there is one licensed SLP in Montego Bay, one in the Discovery Bay, St. Ann area. Everybody else is in Kingston. There's no one in the east. There's no one on the southern coast. It is the problem a lot of people have is that they have to come to Kingston in order to see a practitioner. I see someone mention that the scale has changed. I would be interested to know what it has been changed to. I certainly had sought, when I first came out to Jamaica, I had sought to work at the Kingston Public Hospital, and nothing came of it because the scaling was an issue. They didn't know whether to scale it as a physical therapist in the public health system or to scale it as a nurse or a tech, because they really didn't know much about the profession. And I think that decision and that change is initiated by the health ministry, but also implemented by the Ministry of Finance. And so there's been some hiccups there. Another limitation is that the profession lacks the support and regulation needed. Even though we fall under the Council of Profession Supplementary to Medicine, it leaves the profession itself is so small, it leaves a lot of space and loophole for imposters and unqualified and underqualified individuals who lack the theoretic and clinical training and expertise to offer services to desperate clients and patients, particularly when there is heightened worry and emotion surrounding their child with autism spectrum disorder and pending an ASD diagnosis. I have stressed that it is important for practitioners referring to a speech therapist and to those seeking a speech therapist to do their due diligence. Do not be afraid to ask for qualifications. Do not be afraid to ask for licensure. Do not be afraid to ask to see it. There are people around the island flying under the radar, offering services, and they do not have the prerequisite training. And this can be detrimental to a child, particularly a medically fragile child. And not much is being done, even though alarms have been made. people come out, they fly low under the radar, they disappear for a while, and then they pop up and you hear, oh, I'm sending my child to so and so. Oh, they don't have any training, but they're teaching them something. It should not be accepted. Persons are opening schools in the West, in Montego Bay. Reputable schools and institutions are inviting these people to speak on the profession and on the disorders. It is inappropriate and it is unethical. And we need to raise more awareness about people asking, institutions asking for licensure. Okay, speech language pathology is an autonomous profession and does not require referrals like other allied health professions. So no, it is not required for a mother or father or family to get a referral from their doctor to if they would like to have their child evaluated. I mentioned again licensure, which is written here, and you can read that on your own. The damage, as I mentioned, can be irreparable. And we don't want anything, especially if you're dealing with a child with dysphagia or who has a swallow disorder. Yes, it is despicable. It's despicable. I see you in the chat. Thank you. All right, I have listed here for everybody, and I will send it to the Paediatric Association of Jamaica. I've listed all the members of JASHA who are all licensed, and I will be sharing it so that you can have a directory. I'm scrolling now, as I mentioned, one in Montego Bay, one in the St. Ann area. Everybody else is pretty much in Kingston, including myself. In conclusion, early detection and intervention improves long-term outcomes for the child and the parents and the autism spectrum disorder journey. SLPs facilitate and foster functional communication. Remember, a child doesn't have to be speaking verbally to be functional. We foster functional communication, and that may look very different from one child to the next. And this is to improve the child's overall ability to engage with familiar and unfamiliar communication partners in a variety of social settings. Communication disorders should be assessed early by a licensed SLP to facilitate an early and aggressive approach. SLPs can help children with ASD to improve communication function, which can lead to an increased quality of life and development. Below are my resources, and I am willing to take questions if you have any. Thank you. Thank you so much.
Thank you so much, Miss Anne-Marita Golden. Thank you. This was a very riveting presentation, very comprehensive, and thanks for highlighting the importance of early diagnosis and early intervention, because it makes a difference in the outcome. We will just go to some questions. So for Prof, somebody's asking for, just to reiterate some of the risk factors for autism and the availability of the MChat. You did say that it's available online. And quite a few persons have been asking about where they can get diagnosis and where they can get interventions. So, Prof, over to you.
Okay, so let me take the easy one. The easy question is about the MChat. You only have to Google it. The MChat will come up. The how you use it, how you score it, and what the scores mean. The MChat is used only for very young children. but it's very, very useful for parents and for pediatricians, general practitioners, anyone who wants to just check what is the next step they should take based on a child's developmental score. Ludwig, remind me of the other questions now. The second one was where to get diagnosed.
Yes, Prof.
All right. So within, okay, so screening can be done using the MChat by any health professional or even by parents, as I mentioned. Once screening indicates that you need to have a further evaluation, that further evaluation is typically done by trained professionals. So here's what happens sometimes. So sometimes somebody gets screened and then whichever professional is seeing them says, oh, yes, ma'am, your child is mild. And then they come to the professionals who are diagnosing them, and we have a different method. We have to use standardized methods of treatment, standardized methods of diagnosis, and we may not say that the child is mild. So one of the things I want to caution is about just referring on, saying that you suspect a child has autism and you're going to refer on to a specialist. There are too few specialists, much like speech therapists, there are too few specialists. And this is why the recommendation is that you don't wait until a child sees a specialist before starting interventions. So that's important. And the reason this happened was because waiting lists across the world are long. There are waiting lists in the US, in Canada, in the UK that are 1 to 2 years as well. The fact of the matter is that something that has a prevalence of 1 in 36 is overwhelming systems everywhere in the world. So it's overwhelming the speech therapists, the occupational therapists, the behavior therapists, it's overwhelming everybody. So the places that you can go to get diagnosed in the public sector is the main public sector center is in Kingston. Sorry, everything is in Kingston, at the Child and Family Clinic, which is at the University Hospital of the West Indies. Within the private sector, there are 2 developmental pediatricians, myself and Dr. Andrea Garbott. We welcome anybody else who wants to go and become a developmental pediatrician. It's only 2 of us in the country. So this is another area that young people can think about getting an interest in, because there is a real need. So you get your screening. Once there is a developmental delay that's identified, you should move the child into early intervention services. If a child is not in school, we recommend that you parents enroll the child in school, because school is going to provide that child with some intervention. The government of Jamaica's public intervention program is the early stimulation program that you're going to hear a little bit about later on. We do private early intervention at our office at One of a Kind Kids. So there's public, there's private, and there is access to schools and early childhood centers, which will provide intervention as well, just by being around and engaging with other children. Was there anything I forgot, Ludwig?
Thank you so much, Prof. And I will just add to that, as the PAJ team, we will try to put together some of these resources, both for diagnosis and intervention, and send them out to the participants of this webinar. So that's one of the assignments that I will take on along with the executive, to have this information out there to the participants. You did answer the question regarding the link between ASD and vaccine, that there is no link, but somebody asked the question again. Just wanted to highlight that that has been dispelled on multiple occasions. The
Right.
comments overwhelmingly in the chat is saying excellent presentation and has been well received.
Sorry to interrupt, Doc. So we have a lot of questions in the Q&A, 36 of them. If I could ask, because in the interest of time, if we could have one question for Miss Golding, and then I'll ask Miss Golding and Prof. If you could just click on the Q&A and then click on type answer and type your answers to the questions that are there. We'd really appreciate it so that persons can get the answers live while they're here with us at the moment.
I started doing that already. I'm doing that now.
Thank you very much. So for the live audience, let me just help Dr. Morris because I interrupted him. As a parent with a newly diagnosed child, 4-year-old with ASD level 1, one of the main challenges is his communication. What techniques can I use to help him with the back and forth communication effectively? Miss Golding.
I'm so sorry. I thought that was for Prof. Could you repeat?
No, sure. As a parent with a newly diagnosed child, 4 years old, with ASD level 1, one of the main challenges is his communication. What techniques would you recommend or can I use to help him with the back and forth communications effectively?
That's a challenging thing to answer straightforwardly because I've not seen what the child is able to do. I would have to screen or assess the child. But one thing I do say to parents is modeling. Begin to model for your child speech and language. You are the blueprint. I don't know if that child, what kind of behaviors he or she may have associated with the disorder, but definitely what I would say is enroll the child in social programs or in school, extracurricular activities, and also create opportunities for more input of language and modeling of social skills. That's the best I can say without knowing further details about the child.
Thank you so much. I think that's a good, complete answer. Dr. Morris, over to you.
Prof, I have one more question for you, Prof. In terms of diagnosis, some professionals are uncomfortable making the diagnosis below age 5. So there are some patients who will have sought to access diagnostic services and would have been told that the child is too young for them to make or confirm the diagnosis, and would have to be sent to another professional. And certainly the cost for these services are sometimes prohibitive for some families. How do we get around that challenge? And the other thing is that some of the support services will ask for an assessment, especially the Ministry of Education will ask for a report before they will help with any intervention services for these patients.
Well, that's a lot, Ludwig. All right. So, Ludwig, break it down and let me take it one at a time, please.
All right. So
I can,
the first one is the early diagnosis is what we need.
Right.
But some professionals say they're not able to make the diagnosis below a certain age, which is 5, I hear that a lot. Which I hear a lot.
I hear that a lot. Anne-Marita just mentioned that we're now at a stage where we can make the diagnosis at about 16 to 18 months. The diagnostic tools, the standardized diagnostic tools that we use first only started at 2 years, but they've gone down now to 16 to 18 months. And there's a lot of research going on about diagnosing kids even earlier because of the importance of early intervention.
Thank you, Prof. And then the second question is, how do we get around accessing some of the intervention services? Say, for example, the Ministry of Education, parents are told that they're not able to access services until they have an assessment or a report that confirms the diagnosis.
Well, I'm sure Mrs. Guntergill will tell you later on, if she's on or whoever is representing her from the ESP, that you don't need a report to access the early intervention services at the early stimulation program. It's recommended that once you are referred for services, remember I said we don't need a diagnosis in order to start services, developmental intervention or speech therapy. We don't need a diagnosis, but one should have a plan for the diagnosis to be in process. But once a child has developmental delays, then early intervention can begin.
Thank you so much, Prof. And at this point in time, we will take a word from our sponsors. Let us put our hands together for these first two presenters, Prof. Sam Zwan and Mrs. Golding. Well, I think you can't open your mics, but we can hear the virtual hand claps. We'll take a word from our sponsors at this time.
Thank you so much, Dr. Morris. Good evening, everyone. So I'm Altova Clark. I am a medical rep representing Square Pharmaceuticals today.
Your system is very low. Could you just turn up your mic?
Oh, sorry. Are you hearing me now?
A little better.
Better? Okay.
You good to go, Altova?
Yes. The settings had changed, so I had to readjust. Okay. All right. So good evening again, everyone. All right. So thank you so much for having us. We are very proud to be the sole sponsor for this webinar today, and we're really appreciative for you allowing us to participate and just share a few of our products with you tonight. So as I said, representing Square Pharmaceuticals, and we are located in Bangladesh. And I just want to keep this tagline in mind: quality squarely targeted. And you'll see what this really means after I'm finished with my presentation. So I'm going to begin this evening with some background information. So I'm going to give some background information on Bangladesh itself, just to give an idea of the environment of where we are located. So the population size in Bangladesh is 168 million. When that compares to Jamaica population size of approximately 3 million, you can see the huge difference in terms of how big Bangladesh is. Now, Bangladesh, they are really self-sufficient. So they're self-sufficient in food, in poultry, in food grain, in fish. And they actually produce 98% of their pharmaceutical needs. So in an
Hi, Altova. Sorry to interrupt you. I can hear you. I have on a pair of headsets, but some persons don't. They're probably driving, etc. If you could lift the microphone up to your mouth just a little bit closer, the one that's attached there.
Is
Give me a
this
sound
better?
check. Oh, there you go. There you
Oh,
go.
okay. Sorry about that.
That's all right. Thank
All
you.
right. Okay. So so in an environment like this, this creates an environment where only high quality players can have a presence, and it actually pushes companies in Bangladesh to actually put their best technology practices forward. Right now, Bangladesh was the first country in the world to actually produce generic versions of COVID-19 medicines. Now, I say this all to say, because this brings me to my next point, which we are very proud about. So Square Pharmaceuticals is the leading and the largest pharmaceutical manufacturing company in Bangladesh. Right. We've been around for the past 65 years. We came into existence in 1958. And then fast forward 27 years after that, we hit the #1 spot, and we've been leading since then for the past 30, 80 years. So we are very proud. So we are on our way to becoming a high performance global player. And currently, we export to over 42 countries. And this includes countries in North and South America, countries in Central America, countries in Europe, in Africa, in Asia. All right, so this brings me to our GMP approvals. So we know quality control is a critical aspect for any company, especially pharmaceutical companies. All right, now what GMP refers to good manufacturing practices. So these are just criteria put in place by the regulatory bodies like the US FDA or the UK MHRA, which ensures that manufacturing companies consistently produce products that are of the highest quality and also have the highest safety profile. Now, Square Pharmaceuticals, we have our manufacturing procedures, our manufacturing units, our products. They have all been approved by the US FDA, by the UK MHRA, by the regulatory body in Brazil, in Africa. So I want you to be comfortable knowing that when you choose a Square product, you're choosing quality over anything else. So our global mission. So our owner, Samson Chowdhury, he chose the name Square because a square has 4 equal sides, which represents equality, and perfection, which represents quality. So he wanted a name that basically signifies our global mission, which is to ensure or to basically produce quality products and make those accessible to everyone regardless of social background. So we have 4 formulation units in we have 4 formulation units in for Square Pharmaceuticals. So this one is our unit in Dhaka, and this formulation unit has been approved by the UK MHRA as well as the US FDA, by WHO, by UNICEF. So we've also had representatives from UNICEF who have visited this site, and they have used or they have chosen this site for their global supply as well. So this plant supplies roughly 5.2 billion tablets and capsules each year. So this brings me to my objective. So for the next part of my presentation, I'll be speaking or reviewing the role of azithromycin, fexofenadine, and mometazone nasal spray as treatment options for acute rhinosinusitis. Right, so acute rhinosinusitis. So we chose this condition. So we are going to actually just tell you about a few of our products that is tailored for treating this condition. And we know clinicians who regularly treat patients with autism, they often find that a number of these children may also have chronic allergy problems, such as rhinitis, which is a stuffy nose, sinusitis, and recurrent ear infections. So treating allergies often seems to improve not only the health of the child, but may have a positive impact on function and the autism spectrum disorder parameters, including eye contact, sharing attention, social interactions, and language processing functions. Right, so we know acute rhinosinusitis, which hereafter I'll refer to as ARS, in children is a common condition, and it often requires a multifaceted treatment approach. So ARS refers to a group of disorders characterized by inflammation of the respiratory epithelium of the nose, as well as the paranasal sinuses, and this usually lasts anywhere between 7 to 28 days. The epidemiology of ARS. So the prevalence of rhinitis among Jamaican children, as published in the National Institute of Health, is 24.5%. the global prevalence of ARS is between 6 to 15%. Now, up to 5 to 10% of viral respiratory tract infections in children, they generally progress to bacterial rhinosinusitis, with a number of them developing into chronic rhinosinusitis. Now, common pathogens involved in bacterial ARS refers to Streptococcus pneumonia, Haemophilus influenza, or Marexella catarrhalis. So diagnosing acute bacterial sinusitis, it can be diagnosed in children with an acute upper respiratory infection that persists with nasal discharge or daytime cough for more than 10 days with no improvement. Or these symptoms may get worse after improving at first, or these symptoms are severe with fever of at least 102.2 degrees Fahrenheit or 39 degrees Celsius, along with purulent nasal discharge for at least 3 consecutive days. Now, the role of antibiotics in treating bacterial ARS is controversial. The role of antibiotics in treating ARS is controversial. So in a majority of cases, the sinusitis is triggered by a viral upper respiratory infection, as said before, and that would be unresponsive to antibiotic therapy. So therefore, it is imperative to at least attempt to determine which patient will benefit from antibiotic therapy, and that will be based on the symptoms, to avoid unnecessary antibiotic use, as well as potentiating the development of bacterial resistance.
I also have the microphone again.
Oh, sorry.
So
this brings me to Azithromycin in treating pediatric rhinosinusitis. So we know azithromycin is not a first-line treatment for bacterial rhinosinusitis. However, it is a suitable alternative for use in cases of penicillin allergy, or if you know that compliance may be an issue. Right? Sometimes we know it can be a tedious task of parents to get children to actually take medications. And so in cases like that, giving them something that have a shorter duration of therapy, or give them an option where they administer it once a day as opposed to twice per day, would give you a better compliance, and as a result, give you a better therapeutic outcome as well. So I know it's based on a case-by-case basis for which products or which drugs you'll use for treating the bacterial infection. Now, the efficacy of azithromycin was evaluated for its clinical efficacy and tolerability in treating children with acute respiratory infections. And this was shown in a study that was published in 2013. So they found that a 3 to 5 day course of treatment with azithromycin has proven equally effective. A shorter course increases the likelihood of patient compliance, as I said before. Now, this study used 135 children, and they were treated with a single 10 milligram per kilogram dose of azithromycin for 3 consecutive days. And the result of this is that they displayed 100% resolution of the symptoms in those with acute rhinosinusitis after 10 days, and no recurrences were observed. Right? So the brand of azithromycin that Square offers is our Zymax suspension, which I hope everyone here knows Zymax and writes Zymax for you and chooses Zymax for your patients as well. So we have 3 presentations of our Zymax. We have our 500 milligram tablets, and those are film coated and scored. So for children who weighs more than 45 kilograms, then you can go ahead and give the adult dose or give the 500 milligram tablets. We also have the capsules in 250 milligrams, and then we have the suspension for the children. Now, ours, it's very delicious. It has a cherry banana flavor, and so it tastes and it smells good for the kids. Right? So the adult therapy would be 100 milligram once a day for the 3 days, or for the pediatric dose for babies 6 months or older, is 10 milligram per kilogram once a day for 3 days. So other therapies for treating ARS. So mild symptoms, including low-grade temperature elevations and non-purulent rhinorrhea lasting for less than 10 days. So this would be the non-infected ARS. So the options that we have for treating this would be our Fexa suspension and our nasal spray, which is a mometazone nasal spray. Now, we are so happy and excited to introduce our newest product on the market, and this is our Fexo suspension. So this is our fexofenadine suspension. So it's pretty easy to remember. It's basically a shortened version of the molecule named fexofenadine Fexo, right? And this is specially formulated as a great tasting alternative. So it tastes really well, really great. It has a raspberry flavor. It's a twice a day dosing. It's non-drowsy option as well. And it can be given to children as young as 6 months old. Now our package size is a 200 ml bottle. This is exactly how it looks on the picture, 200 mils. And so that will basically give you more than 10 days treatment with the Fexo suspension. So for the dosage for children 6 months to just under 2 years is 2.5 mils twice per day. For 2 to 11, it's 5 mils twice per day. And for children 12 years and older, it is 10 mils twice per day, right? So if you do have any patients who display rhinitis symptoms and you think that they will benefit from our fexofenadine molecule or Fexo suspension, then please, by all means, go ahead and write the Fexo. In terms of pricing, it is very affordable compared to the brand on the market, right? The cost of our Fexo suspension is $1,761. The cost for the brand is $2,745. So that's basically $1,000 difference between the two. Our size a 200 ml bottle, the brand is a 150 ml bottle. So you're getting 50 mil more with our Fexo suspension, and you're paying $1,000 less than the brand for it. It doesn't get any better than that, right? It works really well. The efficacy is really high. And from what I said before, you can be sure that when you think of any square product, you know that you're getting a quality product, right? Our next product is our nasal spray. And this is our mometazone nasal spray. So this comes in a packet size with 120 sprays per bottle and is 50 micrograms per spray. Now our nasal spray, there is no burning, there is no bitter aftertaste, and it's pure, so it's finely misted particles. It's very comfortable for kids especially to use it. In terms of dosing, for children 2 to 11 years, it is 1 spray in each nostril once per day. And for children 12 years and older, it is 2 sprays in each nostril once per day, right? So this is also a list of our other options or other products that Square currently offers to the Jamaican market. So I hope everyone is familiar with all of these products. And if you do see any indication that requires the use of any of these products, I ask that you write our Square products by name to ensure that your patient is getting a product that is of the highest quality as well as affordable. All right, I think affordability is very important, especially in a time like this, where everybody is experiencing these financial constraints. So time hard, right? So if they can choose a product that is affordable and works great, then there is no drawbacks to that, right? Also, I hope everybody was listening to this presentation, because at the end of this session, we're going to have a Q&A, and we have lots of prizes to give away to persons who answers our questions, as well as our country manager, Tamara Melville Scott. She'll be introducing our Happy and Healthy with Fexo Art competition that has commenced. So thank you again so much for your time, and thank you for having me. Thank you for listening. Good night.
Thank you, Ms. Clark, for having introduced your products, and we are again very grateful for sponsoring this meeting. The task is mine to introduce the next speaker from Myco Care Center, and this is Dr. Sharon Anderson Morgan, and it is indeed a privilege to introduce her, the special educator, teacher educator, and the administrator. She's currently the Director of Assessment and Therapeutic Services at the Myco University College, the Child Assessment and Research in Education Center, She has worked as Assistant Chief Education Officer at the Special Education Unit in the Ministry of Education, Youth and Information. She has also worked at Sam Sharp Teachers College, Granville St. James, as Principal Lecturer and Head of Special Education Department. She has worked as Head of the Special Education Department and Senior Lecturer, and she was also classroom teacher at the Lister Mears Gilby School for the Deaf in Maypen, Clarendon. She has worked as resource room teacher of the Deaf Exeter High School at Ajax, Ontario, Canada. And she is a graduate of the Nova Southeastern University in Florida, where she received her Doctor of Education, Special Education, and she did an elective in Human Resource Management and Professional Development. She also received her Master's of Science in Literacy and Language Arts from the Central Connecticut State University in New Britain. She has done many short courses from the NCT VET, Trumpet Behavior Health, or Autism Pro, and she has PAHO Teen Mental Health Literacy Training. She has done research, the effects of deafness on self-concept, attention deficit disorder, a case study, motivating struggling readers in grade 4 to 8, self-efficacy of Jamaican pre-service teachers for inclusive education, alternative pathways to secondary education, the Jamaican experience. And she has done special projects in her community. That's Caribbean Center for Excellence in Teacher Training, Center for the Advancement of Individuals with Special Needs. And she has done many publications, Principle, Policy, and Practice in Morris, Inclusive Education, The Key to Social Transformation. She has also published an investigation into the self-efficacy of Jamaican pre-service teachers who are working in inclusive classroom, doctoral dissertation. She has done many presentations, and she is a devoted Christian. And I must say, she is from the community in which I was born and raised. Please help me welcome Dr. Sharon Anderson Morgan. Dr. Morgan, over to you.
Thank you, Dr. Morris. Good evening, ladies and gentlemen. It's my pleasure to be here. I want to first congratulate the Paediatric Association of Jamaica on this webinar. So far, it has been very informative and thought-provoking. And as we know, autism is a buzzword, so to speak. Now, my brief presentation will focus on the services of Michael Care Center, where I currently serve as director, as you have heard. Now, Michael Care Center, right, so I have my presentation up now. All right, so Michael Care Center was established in 1981, and it is a Center of Excellence of the Michael University College. It was established as a partnership between the government of Jamaica and the Netherlands government. The Netherlands government provided the building and resources, while the government of Jamaica provided the land. Now, the core business of Michael Care Center is to provide psychoeducational assessment. And this is conducted through a multidisciplinary team approach. And we heard about multidisciplinary teams in earlier presentations, and I'll tell you a little bit more about our teams. We also provide support for parents and teachers of students with special education needs and disabilities through publications, coaching, counseling, trainings, workshops, and a variety of capacity building activities. And in addition to that, we provide various types of therapeutic services. Now, I'll tell you a little bit about the services. So our core business, psychoeducational assessment, and I think Professor Samsvon spoke a little bit about that. And further down, I will explain that a little bit more. We have a licensed speech therapist. It's a very, very recent and something we're very proud about. And so we are now able to do speech evaluations and therapy. And we also have an approach where we provide parent coaching so that, while speech services are limited, the parent is empowered to continue doing activities at home that can build the child's speech language capacity. Currently, we do not have an occupational therapist, but that's a part of our structure. We also do educational research, and we provide public education. We have a number of publications. We publish a newsletter for parents and teachers. We have 2 autism publications currently. One is a resource guide for parents, and the other is a brochure about developing skills in older children. We also have various remedial intervention programs. Some of the clients who are assessed at the center are selected to participate in remedial programs. One of our remedial programs is a 1-term program, so the child will come to us for a school term, and the program will focus on their specific area of deficits. We have a tutorial program, which is an after-school program, and children come twice per week. And we also have summer intervention programs, which is a 3-week program. Now, anyone can refer a child to Microcare Center. Usually, though, our referrals come from parents, schools, and occasionally from other service providers, like doctors, etc. Our process, we have a registration process where we provide forms for the parent to complete. And this is a part of the assessment to be able to get that background information and form a profile of who this client is. So the parent comes in, they're given a general referral form, teacher report form, and a medical form. Medical form is taken to their primary care provider to be completed and returned to us. And some of the indicators that Professor Samsvon spoke about earlier would be on that checklist so that we can see if there are signs of autism and any other disability. We're not primarily about autism. We deal with all disabilities, all particularly developmental disabilities. The general form, the parent completes, and that kind of gives us an indication of why the child is being referred, what are the challenges, what are the concerns, and of course the teacher completes a form so that we're able to match all that data, triangulate the data, and come up with a profile of the child. This is then taken into an intake process where we decide if this is a child to be assessed at Microcare Center or this is a child to be referred to another agency. The multidisciplinary team comprises of a social worker. So each child sees these various professionals during their time at the center. And usually it's not a one-day thing. They sometimes have to come back. Sometimes they can see up to 3 professionals on a given day, but it depends on the case, the complexity of the case, and how long the various assessments take. So they will see a social worker who does a social investigation, and that's not spelled properly, and also does an adaptive skill evaluation. And Dr. Samsvon spoke about assessing adaptive skills. So, and this is done using standardized measures. So they're given like a Vineland adaptive scale. The nurse does a medical screening, talks to the mother about pregnancy and development, did the child meet milestones, etc. Then our psychologists will use standardized measures to do ability tests, cognitive tests, to determine the child's intelligence and all other cognitive factors. They also conduct behavioral screenings. And here is where we will pick up on things like autism or tendencies or features of autism in many cases, and this may lead to further assessment. So, and if the child has speech needs, the speech language pathologist will also do an evaluation, and when an occupational therapist is available, they may also see the child depending on the needs. Now, in any given year, Microcare Center receives over 800 referrals, and that's in Kingston alone. And we do have centers outside of Kingston. We have one center in St. Anne's Bay, and we do operate out of Mandeville at the Ridgemount United Church. So we have 3 locations, and we also do in-school evaluations, do field assessments where our clinicians go out into schools on the request of the schools and does screening, not the full assessment as we do in our center, just screening. Now, you will notice that of the over 800 referrals, we only have a capacity to do about 600 to 700 each year. And from our referrals, what we've been noticing, like everyone else has been saying, we are seeing an increase in the number of clients who are presenting with autism or presenting features of autism. Now, for example, in 2022, of our 841 referrals, and I'm just referring to our Kingston Center now, 99 of those were referred because of autism presentations. However, this does not include clients who may have come for other reasons, but then turned out to be assessed for autism because the clinicians saw clinical presentations of autism, right? And so those would not be included in this number. So the number is actually much more who would end up with an autism diagnosis or be screened for autism. Now, we use standardized tools, and the Childhood Autism Rating Scale and the Autism Spectrum Rating Scale are commonly used tools in our center. The challenge with these tools is that they rely on informants, right? So they rely on a parent or caregiver to provide us with information. And as doctors, you know that, parents see through different glasses, right? They see their child through really different eyes. And sometimes the information provided may not necessarily be accurate. So when you match what the social worker has with the psychologist, etc., it's not coming out to give an accurate profile of the child, and we may doubt the reliability or validity of the assessment process. So we have recently added to our suite of tools the Autism Diagnostic Observation Schedule, the ADOS-2, which is considered a gold standard tool in diagnosing autism. And this is more observation of the child, where the child participates in a number of activities and is observed and scored by the clinician. I already mentioned that there's speech therapy, and our speech therapist sees a number of clients with autism. Now, since we have been seeing an increase in autism presentation, we have been increasing our response. So we've been gradually building our capacity. So firstly, we are increasing our capacity to diagnose and identify autism. And as a previous, I think Professor Sams once said, or maybe someone else said it initially, it's not very easy sometimes to diagnose, because when you've seen one child with autism, you've only seen one, because it's a spectrum and there are variations. And maybe our development, I've raised this with one developmental pediatrician about possible differences in presentations in our population. There may be some nuances as well. And especially when a child has a mild presentation or just mild symptoms, sometimes they're not so easily picked up. So we're trying to increase the capacity of our clinicians to be able to make an accurate diagnosis, so that we are not adding to the wait list by having to refer, because sometimes we screen and then we also refer to one of the developmental pediatricians, which also delays sometimes some of the services that are available to the child. So we're acquiring new tools, like we just acquired the ADOS-2. Our clinicians are being trained in that. No, we have been, over the last 2 years, hosting a number of workshops for parents, parent coaching sessions, where we have occupational therapists, speech therapists, and so on, making presentations, giving strategies. These have been well received. Parents are really, really hungry for information. I told you about our publications, and we also have a number of social media activities where when we have our workshops and so on, we create videos and we also post them on our social media pages so that people can continue to have access to these. We don't currently have an intervention class for children with autism, but we do have children with autism in some of our intervention programs. These would be children with milder presentations. So one of our goals is to develop an intervention program for children with more severe symptoms so that we are able to meet those needs, because we know that it is very challenging for parents to find appropriate interventions. Of course, it wouldn't be long-term intervention. We would bring them in, work on remediating some deficits, and have them included. I am a firm believer in inclusion. Animal-assisted intervention is also something that we have been exploring and doing some research on. There is strong evidence that it works well with some students, building their social interaction and communication skills and their focus and attention, nature therapy, and so on. So we've been talking with some partners and trying to see if that is something that we are able to do. There's also a program that we have been exploring called Autism. And let me just tell a little bit more. Now, ECHOs there's the Autism Institute in the United States, and there are some other countries that have these Autism programs. And they use a particular model of an interdisciplinary approach to training. It's based on a professional model of all teach, all learn. So what you have a hub team that's made up of professionals, maybe like Professor Sams Vaughn and Dr. Garbott, and the people who are the leaders in the field in the particular country. They form that hub team, they develop a curriculum, and then you have participants who will come to a meeting like this and are taught by these professionals based on the curriculum that is developed. Using case presentations. So persons will come, participants will come, present a case, and the case will be discussed. And there's also a presentation, a didactic presentation, which will be done by a hub team member or someone that they have selected. Myself and other members of the team at MicroCare, we have been trained in how to set up an ECHO program. And we are talking with various partners because we believe that this could be a good step for Jamaica because we have so few resources. So it would be a way to replicate these resources and to build the confidence level of various professionals in terms of their knowledge base about autism or whatever the ECHO decides to do. The ECHO could be a parent-focused ECHO. It could be for medical practitioners. It could be for a wide, whatever the developers decide to do. But this is something that we are looking at. We believe that this is a good way we could collaborate with the Paediatric Association of Jamaica so that all our pediatricians can develop that level of confidence and also be trained to screen and identify or know when to refer and so on. So I talked about the various publications that we have done. These are some of the autism workshops which we've held in the last 2 years. Up to April this year, we had a major teacher training workshop where we had 111 teachers participating. We had an autism coach from the United States. Well, she's actually Jamaican, living and working in the United States. Major limitation for us, we have a long wait list, which we are not proud of at all, but it has to do with our human resource capacity and also the intensity of the service that we provide. If a client has to see so many professionals, it takes some time for that to happen. And so we have a long wait list. And as I said before, we don't have any academic intervention program for ASD at the moment. We're working on that. We don't have an OT, we don't have an ABA or applied behavior therapist, and those are also critical to providing the kinds of services. And it's for all the reasons that Ms. Bolden mentioned before, training not being offered here, payment, how persons are remunerated, and all of those factors. But there is hope, and we will continue to work on that. So just some quick recommendations. I believe we need to develop a cadre of professionals who are competent and confident in diagnosing ASD. At Michael Care Center, we don't typically see clients younger than 4 years old. And that's because there is the early stim, and Mrs. Gonzagale will speak afterwards. So we don't typically see between 4 and 18, but we know that autism can be identified and diagnosed much earlier. And we are seeing kids who are coming to us at 9 and 10 and 11, clear presentations of autism, but they've not been diagnosed. They've been told, they'll grow it out, nothing is wrong with them, and so on. So Jamaica needs to develop a cadre of professionals who are competent and confident. We need to engage our tertiary institutions. I know there have been conversations in the past, but maybe we need to come up with a model that works for us, so that we can train ABA, we can train speech therapists, we can train occupational therapists, and have them, lobby our government to properly compensate them so that they can provide these much needed services. Sharing of information between service providers, health and education, social services, we all need to share information so that we can properly plan for the services that our clients need. The health system interacts first with a child. And so for the Ministry of Health to be providing information to education, so education can plan for who they will be seeing in a few years and so on. And we know the social services are critical. The Ministry of Labor and Social Services is the ministry with primary responsibility for disabilities. And so this cross-sharing of information is critical. Public education and training like this cannot be overemphasized. And again, I congratulate the Paediatric Association of Jamaica. We need more of this. Knowledge is power. People will develop higher levels of self-efficacy the more information they have. And so we need to continue to build this awareness. So Michael Care Center, as I said, we are located at 5 Manhattan Road in Kingston. But we have a center in Roy Street, 2 Roy Street, St. Anne's Bay, and we operate out of Ridgemount United Church in Mandeville, Manchester, where you can also connect with us if you want more information through social media. We're on Instagram, we have a YouTube page, our website. We have a website as well. It has some issues at the moment, but we're working on that. So very soon you'll be able to get up-to-date information on our website. So thank you very much, and I will be around if there are any questions when that time comes.
Thank you so much again, Mrs. Anderson Morgan, for this very information on Michael Care Center, and I'm sure that this has been well received, and I can see that persons are saying great presentation. And we are being empowered to help children with autism and their families. So we will have questions after the next presentation. We go over to Mrs. Antonica Gunter-Gale from the Early Stimulation Program. But first, let me introduce her. Mrs. Gunter-Gale has been working with the Early Stimulation Program in the Ministry of Labor and Social Security for the past 35 years. She has worked in the capacity of Child Development Officer, teacher or supervisor, and presently as Director or Principal of the Early Stimulation Program and Stimulation Plus Child Development Center. Mrs. Gunter-Gale is an advocate for children with disabilities and has been championing the cause for education and special intervention for the nation's children with special needs. She currently sits on a number of committees and boards and is a past member of the Early Childhood Commission. Mrs. Gunter-Gale has done studies in early childhood education, early intervention techniques for children with disabilities, community-based rehabilitation for children with intellectual impairment, social work, amongst others. She is presently a PhD candidate She holds a degree in guidance and counseling and a master's in education. She's the recipient of a number of awards, including an award for long and dedicated service in 2012, the Badge of Honor for Meritorious Service to the Nation's Children by the Governor General in 2014, and was again awarded the Order of Distinction for Excellent Services to Children with Special Needs in Jamaica in 2017. Mrs. Gunter Gale is a Justice of the Peace and a loyal Jamaican who continues to serve her country with pride, dignity, and respect. Please help me welcome Mrs. Gunter Gale to talk to us about the Early Stimulation Program. Over to you.
Good evening, everyone. Just want to say a big thank you to the Paediatrics Association for inviting me to share. My task this evening is to share with you about the services of the Early Stimulation Program. So the Early Stimulation Program is a program of the Ministry of Labor and the Social Security that works in collaboration with the Ministry of Health, the Ministry of Education, Special Education Department, Early Childhood Commission, and a number of other institutions. The Early Stimulation Program seeks to provide early intervention services for young children. See the screen? I'm trying to share the screen. Can you see the screen?
Yes, we can. Thank you very much.
Thank you. And so the Early Stimulation Program seeks to provide services for young children and their families with various types of disabling conditions. Well, among the disabilities managed by the Early Stimulation Program are those with children with learning disabilities, children with autism, children with intellectual impairment, children with cerebral palsy, those physically challenged, those with attention deficit hyperactive disorder, ADHD, those with visual and hearing impairments, those with cultural familiar retardation or impairment, and multiple disabilities. I must say, though, that among these disorders, we serve more children with autism than any other disorder. Presently, we are serving more children with autism. The greater percentage of our children are those with autism. Children are referred to the program by healthcare workers, or they can be referred to the program by healthcare workers, early childhood practitioners, social workers, guidance counselors, both public and private practices, and other parents who have benefited from the service from time to time will also refer other parents and families to the program. Now the program includes center-based services and community-based services. Center-based services includes a developmental screening. So we see where the child is at. For us to start a program, an intervention program, we would like to know where this child is at developmentally. And so we do an in-depth developmental screening to see what is happening. Our review processes. So the child is admitted to the program. After the screening, we do a 3-monthly review process to see what is happening. Is this child improving? Do we need to change the tailored activities or tailored program? We provide therapeutic services, early intervention, counseling, physical therapy, parent orientation, parenting workshops, special early childhood education, parent support groups, and so on. Our community-based services includes home visits. And so we take the program into the homes of the children. If they're at home, then the program is taken into the home by trained child development officers. If the child is at the nursery or in schools, we do visit the schools and we do pull-out sessions with the child at school. If the child, we provide training for the parents and the caregiver in stimulation, how to, through various techniques, how to assist this child at home, how to use junk materials from around the house or from around the home to stimulate this child. Not necessarily to go and purchase expensive teaching, learning, or stimulating materials, but how to use the baby feeding tin, how to use the macaroni box, how to use various items around the house to stimulate this child. Our community-based rehabilitation is carried out by trained child development officers, as mentioned, who really have a one-to-one with the caregiver or the parent and the child. ESP at a glance, community-based intervention, physiotherapy, parent counseling, parent training and support groups, public education, social activities, sports day, fun day, where all the children can come out along with their parents and family members and enjoy, social activities where the child with special needs can, be a part, they can participate as much as possible. Reviews, referrals, where we see that, the child need to be referred apart from the ESP, there are other services or other needs for this child. And so the child is referred, whether to schools, for medical and further assessment and so on. So we have a referral systems, review and reevaluation, behavior, also a behavior modification program is set for the child where needed. What are some of the parishes? How, the children are seen in Kingston and St. Andrew, St. Catherine, St. Thomas, St. Mary, Portland, St. James, St. Elizabeth, and St. Anne. So we presently serve these parishes. Our latest initiative is the Mobile Intervention Unit. And this Mobile Intervention Unit that is retrofitted provides therapeutic and educational services to children with special needs from birth to 6 in rural communities. And so we say Kingston is not Jamaica. And so we try to take the services into some of the rural communities across the island, where we find that our families out there are so grateful and excited, to receive the service. It is difficult for a mother, a parent with a child, say, for example, with hydrocephalus, to take the regular public transportation to get to Kingston, or a child with spastic quadriplegia to come all the way to Kingston to, get the service. And so we take the service out there in the communities to our children with special needs. And when I say special need, this includes the various disabling condition, be it autism and other intellectual disabilities and so forth. We are presently seeing 1,532 boys are male, and in the urban communities, Kingston, St. Andrew, 827 female, a total of 2,359 children are being seen. Out in the rural communities, we are serving, 524 male, 318 female, a total of 842 presently. The early stimulation presently serves 3,201 children with special needs. And there is a picture of our mobile intervention unit where we go out in the communities to carry out the intervention. These are some other pictures of our Child Development Center, Stimulation Plus. We have reopened last week, Monday, and last year we had a total of 120 children attending the center daily. This school year, we have 172 children attending the center for stimulation and therapy. So that's Stimulation Plus Child Development Center. We also have another center over in Portland, Orange Bay, Portland, that serves Portland and its environment. We also have a program over there in Portland where a community-based program as well, where we go into the hills and valleys of Portland and in its environment to serve our children with developmental disabilities. Stimulation Plus children at school. Our graduation at the end of the 6 years. So as we said, from birth to 6, at the end of the 6th year, we do have a graduation where our children, will go off the primary level, whether it be special education programs or go off into the regular school system. Some children are able to mainstream at the end of the intervention program. Some children will go into a regular school system, while some will enter the special education programs. Our valedictorian with severe cerebral palsy was able to move the crowd on graduation day in July with his speech. And so we encourage our parents, don't sit and wait. We say the sooner, the better. We encourage our parents not to sit and wonder if the child will grow it out, or, sometimes we still find parents coming to us thinking that this might be a spell, or, with a lot of myths and superstitions that somebody has caused this to happen. We encourage them, early stimulation and early intervention makes a difference, is the best. Do not sit in disbelief and all sorts of ill thinking. Rather, you should try to access intervention as much as possible. We have a number of challenges. This includes, while we are able to see persons from all across the island, we do not have centers in all parishes. Presently, we have a center over in Portland, as I mentioned earlier, 2 centers in Kingston and 1 center over in St. James. On a second Wednesday, we go over with our mobile unit to the Brownstown Primary, where we see a number of children. We also go over to Santa Cruz, in St. Elizabeth on a third Wednesday, where we also see a number of children, including children with autism. So we have a long waiting list. We have the need for a speech therapist, and we do not have centers in all parishes. I think that's it. I think that's the end of my presentation.
Once again, I want to thank you, Mrs. Gunter Gale, for that presentation. I'm sure that every single person on this webinar was moved by that picture of the valedictorian, and it really highlights the great work that your organization is doing. There are a lot of comments in the chat saying great work, very informative. So we will take some questions from the question and answer. First, I'll start with Mrs. Anderson Morgan. There is this question that repeats itself several times. How can these programs be replicated to persons in early childhood institution? And I know that you mentioned that that's part of the program that you offer. So it's a question and it's an invitation, I'll say, that with the Paediatric Association of Jamaica, that how is it that we could partner to deliver this kind of program and information to persons in early childhood institution to be able to identify and refer appropriately?
That's a very good question. I think Professor Samswan could also speak to what I'm about to mention, but there is a course that was developed for early childhood practitioners to do just that, to help them to identify and provide services, educational services to children with special needs and disabilities. I believe she might have been a part of the development. I think it was a UNICEF-sponsored project. So that's there. But for my part, any educator can reach out to Michael Care Center and we can provide workshops for you directly. We can customize it based on your needs. And we have a wealth of resources on our YouTube channel. That's something we try to do because that will always be there for persons to go back to. So we have many workshops, presentations, interviews that we do, like with parents and service providers. So lots of information is there on our YouTube channel. But I do agree we can partner to put a formal program of training together to be delivered to our early childhood practitioners, because that's where it starts.
Thank you so much. Sorry, go ahead, Mrs. Gale.
No, I was just about to say I'm in agreement with Dr. Morgan, that we need to partner and to look to see how best, we can assist with that.
Thank you.
Logic, if I could comment, there is a course that I had developed that's designed specifically for early childhood institutions, and that's what Mrs. Anderson Morgan was referring to. The course is under the direction, it was funded by UNICEF, and it's under the direction of the Early Childhood Commission. It was developed and handed over to them. It's an online course, and it was designed specifically to support children, because a lot of the times the children get excluded, even though it's against the law in Jamaica to exclude children from early childhood institutions. A lot of the times children get excluded when inclusion is the best thing for them. And so the course was designed, a lot of the teachers say, we don't know what to do with these children. And so the course was designed and developed for that purpose. So it's online. The Early Childhood Commission rolls it out ever so often. I think They do between 30 and 50 persons each time. And they're trying to make sure that at least one person in each early childhood institution is trained in that course.
Thank you so much. Know that we have this knowledge, we are empowered to act on it. And certainly in, well, I can say that majority of the persons on this webinar might not have known about this course, because many times we ask that the children just enroll in preschool as an intervention, whilst it is that they wait on their assessment and other things. And it's difficult to get some of them into preschool because of the behavioral issues that comes with the condition sometimes. And so they make a lot of crisis calls to their clinicians and other persons, just trying to get help for their children. And so empowering early childhood practitioners to understand and deal with and appropriately is certainly welcome. Thank you so much. There's somebody asking, what is the qualification to be a developmental practitioner?
For you, Mrs. Gonta-Gail, developmental officer, I think.
Yes, child development officers.
They want to know what's the qualification.
Oh, okay. I didn't hear that. And so a number of our child development officers have training in early childhood education, a degree training, child development therapy. Professor Samvon would know about that one as well. Quite a number of our staff had received training in child development therapy. We have staff also with child and adolescent development training, child development officer through the University of Technology, guidance and counselors, social workers.
All right, and Mrs. Sorry, go ahead, Prof.
So the associate degree in child development therapy was commenced at the UWI. The design of it was that it would create an intermediate level person who could provide support to children who need early intervention. So it was run as a face-to-face course, and the intention was to convert it to an online course. That happened just before COVID, so we haven't gotten back on track. It was funded by UNICEF again, and indeed, lots of persons have been asking for it, including right across the Caribbean, so that we can increase the capacity of persons to work with children with special needs. But the intention is to get it going.
And there is one parent who's asking, say that she's parent of a 6-year-old who had regression and is now learning again. Are there any tips or pointers that you'd love to give her? Prof, Mrs. Dr. Morgan, Mrs. Gonta-Gail, any tips that you would love to give to her?
I think the question is a question specific to speech. I think I saw it.
I think it was specific to speech. So I was just going to say, and I think Anne-Marita answered a similar question when she said the important thing is about modeling. Just modeling speech for children, labeling things when they say things, adding to it. So if a child says car, you say red car. You add to it, and of course continuing to have conversations with children even if they are nonverbal, and allowing them to respond nonverbally.
And having them in very inclusive environments is very important. They'd be surprised what enrolling, say, a nonverbal child in a group activity can do for that child. I always encourage sporting activities that require cooperation, because those things help to model behaviors and language for them that can be very useful.
Thank you so much. And here is a question for you, Mrs. Gale. When are you going to expand the ESP to other rural communities? You don't have to answer that question right now, but I'm certain that that's something that you'd love to do.
Oh, yes, definitely so. And we are looking at various, ideas and discussion, in regard to the expansion. So I'm sure, you never know anytime soon.
Well, certainly, I'm sure that Westmoreland is the next place for that service, right?
Oh, yes.
Again, I would like to thank all the presenters for such informative presentations. They were well received. And thank you so much for taking the time out to be with us and spending the night with us. I'll just ask the sponsors to have a quick question and answer session, and Dr. Crawford will give the closing remarks.
Good night, everyone. I am just trying to fix something here on my slide. All right, good night, everyone. I am Tamara Melville Scott, Country Manager for Square Pharmaceuticals. And Square Pharmaceuticals is proud to be the exclusive sponsor of this year's PAJ seminar. So I'm aware that some of you were not able to clearly hear Altovia's presentation. So I am just going to summarize it in 2 quick sentences. All right, so a disproportionate number of children diagnosed with autism also have chronic allergy problems. Allergic rhinitis and sinusitis are linked to each other, and therefore we thought it applicable to have this presentation during this seminar. Some of the Square Pharmaceutical options to treat these conditions, acute rhinosinusitis, kids with allergies, we have our newest product, which we are proud to introduce, our Fexo suspension, which is 200 milliliters, and it is it has a sweet raspberry flavor. It's non-drowsy and also has a convenient twice-a-day dosing. We also have our Zymax, which is our azithromycin. We have it available in the 15 and 30 ml, which is very convenient to kids. And we also have the 250 and 500 milligram presentation as tablets and capsule. And we also have our nasal spray. So I am excited to share more details with you about our Happy and Healthy with Fexo art competition. And I believe it's quite appropriate in this forum because art fits naturally with autism in that it can help those with autism express themselves through images while also being soothing to them. So I'm going to just share some details regarding the competition with you. It is, So it is open to children between the ages of 6 to 12 years old, and it is powered by Square Pharmaceuticals. And it is open now, so the competition has begun and it runs through to October 9th. The winners will be announced on October 16th, which is World Allergy Awareness Day. So Square Pharmaceuticals is dedicated to provide not only high quality pharmaceutical solutions, but also empowering our youth through education and encouraging their creativity. So we're asking you to help us to spread the message of children being happy and healthy although they have allergies. We want to empower our kids through education and creativity. And the prizes, we have some fabulous prizes. We have cash prizes for the winners. We have prizes for their schools, art supplies valued at the amount shown there on the screen, as well as a winning school will get 10 drawing tablets and also a mural of the winner's drawing. So I believe it is applicably placed considering autism. If you have your autistic patients and who are in the category, age category to participate, I'm encouraging you to have them enter. You can scan the QR code that is on the screen, and it will take it directly to the landing page. We'll get more information about the competition. And also for our doctors, for all our attendees, I'm asking you to help us share this message. And apart from scanning the QR code, we also have the direct URL, rawilliams.com/health tips. And also you can go on our RA Williams social media pages, Facebook or Instagram. It's ra.williams distributors. And so please, I know that you have probably your children or young artists, your patients, your autistic patients. Let's spread the news and make this competition great. Thank you for having me. And Camille is going to do the question and answer session. So if you are listening keenly to Altovia's presentation, then you would be able to possibly win some of the fantastic, win a lovely basket from Square Pharmaceuticals. Thank you for having me.
Good afternoon, good evening, everyone.
Hi, Camille. Good evening.
So I'm Camille Slater. I'm one of the medical reps from Square Pharmaceuticals. And I must say, what a presentation. It was very informative. Now it's time to unwind and have a little fun. So I'll be doing the question and answer segment for our lovely basket. So we have 3 questions and 3 questions. So participants will put their answers in the chat. The host would help me to choose the winner alongside with my team members. When the winners are selected, we'll ask you to provide us with your contact details so we can have the baskets be delivered to you. So the first question on the screen is, where is Square Pharmaceuticals located and what year it was established? So I see a Stacia.
All right, so some persons are putting where, but not the year. Remember, it's where and when. And the first person that I see who put the where and when is Stacia Goodlit Betty.
Yes.
So Stacia Goodlit Betty, congratulations. I think that makes her the winner, right?
Yes, she is, and thank you. Our next question is.
Hold on a second. So the next question, ready to go, Camille?
Yes, I am.
All right, here we go.
The next question is, what is the name of Square Pharmaceuticals mometazone nasal spray? So we have Awaysome Blake.
All right, a lot of answers, a lot of answers. All right. So the correct answer is nasal spray. And the first person who typed nasal spray in the chat was Mr. Malik McLeod. So Malik McLeod, Malik has won.
Congratulations, Dr. McLeod. Our next question, so the final question is, what is Square Pharmaceuticals' newest product and its package size?
All right, whole heap of answers. All right, whole heap. And the correct answer is?
I don't see anybody with no correct answers yet.
No? All right,
No.
keep going. Keep going.
Yeah.
Keep going. All right, so the correct answer is Fexo suspension 200 milliliters. And the first person who actually said Fexo 200 ml, if you'll accept that, can we accept that? Fexo 200 ml, we'll accept that?
No, the suspension is missing. So the first person with the Fexo suspension 200 ml will be automatically be the winner.
Oh, Shanique, you were so close, but you typed Flex. How about if they type Fexo SUSP 200 ml? Will you take that?
No, I want the correct spelling.
All right, I agree. Fexo suspension 200 milliliters. The winner is Peter Gay Clemmings.
All right, congratulations, Peter Gay. Remember, all winners, could you put your information in the chat, or you can send the information to Sam and he will pass it on to us.
All right, so we want to congratulate Peter Gay Clemmings. We want to also congratulate, who are the names? I hope you were taking the names for me, Tamara.
One is Malik Peter Gay, and the first person was
Stacia Betty.
Stacia, yeah.
All right, perfect. All right, congrats.
All right, I want to say thank you for having us. I want you to enjoy the rest of your night.
All right, Dr. Morris, back to you to wrap up today's wonderful webinar.
Okay, Dr. Crawford will bring us the closing remarks. Over to you, Dr. Crawford.
Not seeing Dr. Crawford. What's Dr. Crawford's first name? Rochelle? Dr. Morris, we're talking about Dr. Rochelle Crawford?
That's right. Okay, so she's not here.
She's here. She's over on the attendee side.
Hi, good night, everyone, and thank you again for joining in on our presentation tonight. It was very fascinating to hear from all the speakers, and thank you again to Square Pharmaceuticals for sponsoring this event. I would like to thank Prof. Sams Vaughn for highlighting the importance and the global prevalence of autism. As she mentioned earlier, it's now 416% increase worldwide. So it's obviously a large increase and a large burden on society now that we're trying to address through all these interventional services. And also she mentioned the Jamaica Autism Association as a support group that our parents can access. And thanks again for the little refreshers on the clinical symptoms to look out for and signs of autism that we're going to carry on during our clinical practice going forward. And of course, the need for interventional services that these patients need to access going forward. Also, thanks to Ms. Anne-Marita Golding for highlighting the importance of speech therapy as a need to provide functional communication in our patients to improve quality of life and development. As she mentioned, we need to make sure we refer to licensed speech and language pathologists, because of course, there are quite a few persons out there who are not doing due diligence to our patients. So we need to make sure that we speak to a proper professional in providing these very important services to our patients. And of course, there's a need for speech and language pathologists worldwide, especially in Jamaica. So it's something to think about for those persons who are interested in this very important field going forward. Also, thank you to Dr. Anderson for speaking to us today, from Michael Care. I learned so much about the services offered there with the Echo Autism happening, which will be starting shortly, along with, as well, she had mentioned, of course, the new speech and language pathologist who is now there to commence speech therapy, so we can now safely send our patients there who can't afford the private speech therapy to access these services publicly, the Michael Care at a reduced cost as well. And of course, not to forget our early stimulation program, who has been so helpful for us over the last few years in providing services to our patients who have either cerebral palsy, autism, spectrum disorder, hydrocephalus, as mentioned earlier, and of course, the mobile unit, which is there to provide these services to patients who are in the rural areas. So we are so thankful to have all these persons to assist us in our patients who have autism. And of course, as mentioned and stressed earlier throughout the presentation, we need to have inclusivity for our patients, enroll them in regular schools. A child should not be denied the right to schooling at all. So make sure they're enrolled in school, labeling, modeling behaviors, and of course, to seek early interventional programs before even the diagnosis is made. So thank you all for joining us. Thank you, Square Pharmaceuticals, and thank you for that very exciting game at the end. And I hope you all enjoy your night. And thanks to the PAJ for putting on this very fascinating and exciting presentation. Thank you all for coming, and good night.
Thank you so much for your time and for being here, Dr. Crawford. I want to say thank you to everyone for joining. What a wonderful evening. It has been fabulous. This has been the Pediatric Association of Jamaica's Autism Seminar, sponsored by Square Pharmaceuticals. I want to thank Square Pharmaceuticals for being the sole sponsor of today's wonderful webinar. Cheers to everyone. Please stay safe. Have a wonderful evening. Thank you for joining. And we look forward to seeing you at PAJ's next event, which will be in October. Look out for those emails. Have a safe and wonderful night, everyone. Bye-bye.